Right, so in the second lecture I put together a series of cases, all of which are real cases that illustrate some of the principles that we reviewed in the physiology lecture, and hopefully will give you an idea of how that knowledge of the physiology can be applied to pathophysiological disease situations. So we're going to start with the case of hypercalcemia. This is a 60-year-old man with a 2-year history of non-specific symptoms, including fatigue. He had one previous episode of hematuria, blood in the urine, but didn't have any symptoms of thirst, polyuria, constipation, or bone pain. At the time that he presented, the investigations are as shown on this slide, and of note he had an elevated serum calcium. The normal range for each of these analytes is shown in parentheses on the right. We're able to measure the ionized calcium, and that was done in this case, and it was not unexpectedly, it was elevated as well. The phosphate level was at the lower part of the normal range, and this TMP-GFR is a measure of urinary phosphate loss, and such that a low measurement, as in his case, indicates impaired ability to reabsorb phosphate. So he had evidence of hypercalcemia, borderline hypophosphatemia, and renal phosphate wasting. As we talked about further investigations showed that he had normal renal function and moderately elevated urinary calcium excretion. So the question obviously is, what's going on here? And as we talked about in the first lecture, in the setting where serum calcium is found to be abnormal, the next test to perform should be a parathyroid hormone level. Just to review the causes of hypercalcemia, they can be divided, as you recall, into parathyroid hormone dependent causes, of which primary hyperparathyroidism is far and away the most common, and independent, and the other one is familial hypocalciuric hypercalcemia, or familial benign hypercalcemia. And the parathyroid hormone independent cases, which are mostly cancer associated and occasionally vitamin D toxicity. And that sort of relatively small list of diagnoses accounts for the vast majority of cases of hypercalcemia. So most likely he has primary hyperparathyroidism, and that's a not uncommon condition in older individuals, many of whom have no specific symptoms related to the usually mild and stable level of serum calcium. Just to remind you about the actions of parathyroid hormone, that increases in parathyroid hormone act to restore or increase the serum calcium by directly influencing or increasing renal tubular reabsorption of calcium, by stimulating bone resorption to increase the flux of calcium and phosphate from bone into the extracellular fluid, and through an indirect and long loop mechanism stimulate the renal 1-alpha hydroxylase activity that is responsible for the conversion of vitamin D precursor 25-hydroxyvitamin D to the bioactive form calcitriol, or 1,25-dihydroxyvitamin D, which increases serum calcium by stimulating intestinal absorption of calcium and phosphate. I apologise, somewhere along the line I've lost my slide there which told you that he had an elevated parathyroid hormone level, making the diagnosis of primary hyperparathyroidism. That diagnosis is almost always attributable to a solitary adenoma involving one of the 4, sometimes 5 parathyroid glands, and is often asymptomatic and not associated with any specific complications. However, renal stones are more commonly observed in patients with this condition, and while this man was undergoing investigations, he had some more hematuria and abdominal pain, and was found to have a large bladder stone that was probably of renal origin that required surgical removal. He underwent neck exploration, and a left inferior parathyroid adenoma was removed, after which he became normocalcemic. More recently, there has been the development of improvement of ultrasound technology for examining parathyroid glands, and we're a little bit better at detecting these adenomas, which are often quite small, by ultrasound or by nuclear medicine scans using sestamibi. And these days, this is a case from a few years ago, usually one of those imaging modalities would be intercalated between diagnosis and surgery to an attempt to assist the surgeon by identifying the source or the site of the parathyroid gland abnormality. Here's a second case of hypercalcemia, just as a contrast. Again, a man of a similar age, 68, who complained of left-sided chest pain dating back about 3 months. He had past history of hypertension, gout, and chronic bronchitis that was on the basis of long-term cigarette smoking, about 25 pack year smoking history. This was his chest x-ray at the time of that presentation, and what one sees, as the arrow helpfully indicates, is a pleurally based mass. If you can look just in the direction of that arrow and compare it to the other side, you can see that there's a clear asymmetry, and he has an abnormality there. He underwent bronchoscopy, so direct visualization of the bronchial tree, which wasn't able to detect an abnormality, probably because the lesion's quite peripheral. He then underwent a CT-guided biopsy of that mass, and that was found to be a squamous cell carcinoma. At that stage he was offered surgery, but he declined it, and was discharged and lost to follow-up. 12 months later, he represented with gastrointestinal bleeding, and gastroscopy at that time demonstrated ulceration of the pylorus of the stomach. At that stage, he had developed a number of symptoms suggestive of advanced malignancy, with weight loss, musculoskeletal aches and pains, but he also had thirst and polyuria, and he was found at this point to have quite marked hypercalcemia, with an albumin-adjusted serum calcium of 3.22 millimole per litre, frankly low serum phosphate, again normal renal function, but he had so he has cancer and hypercalcemia, and if you recall from the earlier lecture a discussion of how cancer might cause hypercalcemia, the most common cause is the secretion by solid tumours of the parathyroid hormone related peptide, and that's very classically associated with squamous cell carcinoma of the lung. Can also be caused by multiple lytic skeletal metastases, as in especially multiple myeloma, or next most common cancer to cause the hypocalcemia by that mechanism is metastatic breast cancer. This man had a repeat chest x-ray done at the second presentation, which showed that the mass that was previously seen in the x-ray on the left at the time of presentation had very substantially enlarged over the 12-month interval. And he was found to be hypocalcemic. You'll recall the next test to do was a parathyroid hormone level that was undetectable, indicating that he had parathyroid hormone independent hypocalcemia. In this case, parathyroid hormone related peptide was measured in the circulation, and usually it's undetectable. In this case it was clearly detectable, and demonstrating that this was a case of humoral hypercalcemia of malignancy, typically caused by parathyroid hormone related peptide production by the tumour. Hypercalcemia of malignancy is, if possible, to treat the underlying cancer, since that will reduce the production of PTHrP. For palliation of symptomatic hypercalcemia, bisphosphonates, which potently inhibit the osteoclastic bone resorption component of the hypercalcemia, can provide short to medium term relief from the hypercalcemia. But as in this case, the hypercalcemia tends, when it does occur, tends to be a late stage accompaniment of malignancy. Alright, here's a case of hypocalcemia. This is a 74-year-old woman who presented with a short history of bone pain and decreasing mobility on the background of a longer history of 2 years of diarrhea and quite substantial weight loss of 10 kilograms. And she'd recently been found to be anemic with both folate and iron deficiency. On physical examination, she was thin, very thin, in fact cachectic, had generalized muscle wasting, and was unable to rise from a chair unaided. So she had a myopathy, particularly affecting the proximal lower limb muscles. She didn't have a neurologic deficit, and she complained quite a lot of bone pain. This was her biochemical findings, and you'll note that she had hypocalcemia with also a low plasma phosphate, so hypophosphatemia, a very markedly elevated alkaline phosphatase level. You'll remember that alkaline phosphatase is an enzyme that's elaborated both by the liver and by bone. Her other liver tests, including gamma GT, as shown here, are normal, which strongly suggests that the alkaline phosphatase elevation in this case is coming from the skeleton. One could confirm that by measuring a more specific marker of bone turnover, such as P1NP, which is only really produced by the skeleton. So that combination of biochemistry suggests that she has osteomalacia, since impaired bone mineralization is almost always accompanied by elevated levels of biochemical markers of bone turnover. And why should osteomalacia? Well, more biochemistry was done. She was found, remember, she had a low serum calcium, so the next test is a parathyroid hormone level, and it's appropriately elevated, as you would expect from physiology, when the serum calcium is lowered. So the feedback loop is intact. Why is she hypocalcemic and hypophosphatemic? Well, she has vitamin D deficiency, so the analyte which reflects body stores of vitamin D, 25-hydroxyvitamin D, was in her case undetectable. And remember that she'd been found to be anemic, both iron and folate deficient, and had diarrhea and weight loss. That combination of findings suggests that she might be malabsorbing. Remember, vitamin D is a fat-soluble vitamin, and when fecal fat levels were assessed, they were markedly elevated. So she has evidence of marked malabsorption causing vitamin D deficiency and hypocalcemic, hypophosphatemic osteomalacia. Why has she got that is the question. And before we answer that question, let's look at the bone histology. So she had a bone biopsy. You'll remember that I suggested that this biochemical picture and clinical picture suggests that she has osteomalacia, and the diagnostic feature of osteomalacia is unmineralized, increase in the amount of unmineralized bone or osteoid, which in this bone biopsy taken from the iliac crest stains pink. And there should be very small amounts of unmineralized osteoid through across the bone surfaces, which are labelled black in this slide, with the lighter areas between the bone trabeculae representing bone marrow space. So you can see that almost all of the bone surface here is covered with pink unmineralized osteoids, so confirming that she has osteomalacia. Why is this happening? She has celiac disease, probably the most common form of malabsorption, and as you'll probably know, it's characterized by total villus atrophy, so biopsy of the duodenum, which is undertaken in her case, shows on the right very marked or absence really of the normal villus architecture, which is shown in the slide on the left, which provides the enormous surface area in the small bowel that allows absorption of nutrients. So the treatment for her is to restore vitamin D levels, which are pretty easily done by loading with oral vitamin D precursors, and a gluten-free diet, which if she adheres to it will lead to normalization or near normalization of the intestinal histology and function. So she had osteomalacia, and just a quick word on osteomalacia is a disease of impaired bone mineralization. That is the kind of process by which the calcium and phosphate is incorporated into the bone structure matrix to provide strength to the bone. It's a histologic diagnosis, and characterized by the accumulation of unmineralized osteoid, as we saw on the histology slide earlier on. When you think about why bone might fail to mineralize, it could be because there's deficiency of either of the substrates, calcium or phosphate, so calciopenic or phosphopenic. In cases of vitamin D deficiency, both calcium and phosphate tend to be deficient. Calciopenic osteomalacia can occur as a result of any malabsorptive state. Vitamin D deficiency, so severe sunlight deficiency, and sometimes a result of disordered vitamin D metabolism. Phosphopenic osteomalacia can also occur from low vitamin D levels, but it can also occur from increased renal phosphate loss, and you'll remember that those hormones called phosphatonins, which activate or increase renal phosphate loss, are generally involved in the induction of phosphopenic osteomalacia. Occasionally osteomalacia is caused by dysfunctional osteoblast, the bone cell type that's responsible for bone formation, and that usually relates to toxicity in days gone by when aluminium was present in the dialysate of patients undergoing renal dialysis, that would sometimes accumulate in bone and cause osteomalacia, and one of the older bisphosphonates, when given continuously, etidronate, when given continuously, could also poison osteoblasts and cause osteomalacia. Rickets is the name given to osteomalacia that occurs in childhood. Just to remind you about vitamin D metabolism, because this is what was relevant to the patient we discussed. We get some vitamin D in our diet. Most of it we get from sunlight exposure, and the bioactive form of vitamin D is the 125 dihydroxyvitamin D moiety, which impacts on calcium and phosphate metabolism by stimulating gut absorption of each of those minerals. In the case of this patient, she had marked malabsorption, so any dietary component of vitamin D would not be being absorbed. She'd also be directly malabsorbing calcium and phosphate, and because she was getting progressively more ill and housebound, she was also lacking the sunlight component or activation of vitamin D metabolism. So all of those factors combined to produce the phenotype that was observed in her. Let's go over that slide. So there's just a recap really that the most common cause of vitamin D deficiency is sunlight deficiency, and we talked in the earlier lecture about the at-risk groups for sunlight deficiency, if you like, being housebound or institutionalized elderly. Remember that the skin becomes less efficient at responding to the UVB radiation component of sunlight in older people. Also individuals who with pigmented skin, because the pigment screens out the UVB component, and individuals who cover up and protect their skin for cultural or medical reasons from sunlight. Occasionally one can see vitamin D deficiency induced by accelerated catabolism of precursor metabolites, and the classical instance was seen in response to some of the early anticonvulsant therapies. It's not really a problem now with the newer anticonvulsants. In patients with renal impairment, advanced renal impairment, and impaired ability to hydroxylate vitamin D from its precursor to the active form, are also prone to hypocalcemia and, if untreated, osteomalacia. It's one of the reasons why individuals with advanced renal failure are sometimes taking bioactive forms of vitamin D. So finally, poor diet or GI disease can contribute. Mostly, as in the case of the patient we discussed, the GI disease which mitigates against calcium or phosphate absorption, so any malabsorptive condition, rather than dietary deficiency of vitamin D. Alright, here's another case of hypocalcemia. This is a young man, 30-year-old, presented with seizures at the age of 20. And his serum calcium was low, his serum phosphate was at the upper limit of the normal range. The PTH, parathyroid hormone level, was appropriately, or actually very high, in response to the low serum calcium. And he was not vitamin D deficient, though you wouldn't think he would be, because the phosphate level is normal, and vitamin D deficiency tends to cause hypophosphatemia. Notably, he was short in stature, and he also had short fourth and fifth metacarpal and metatarsal bones in his hands and feet. So he has the syndrome of parathyroid hormone resistance, or pseudo-hypoparathyroidism. So he's got lots of parathyroid hormone, it's just not working. And a very classical and typical phenotype of individuals with this condition is the short fourth and fifth metacarpals and or metatarsals, as shown by the arrows in this X-ray. Compare the fourth and fifth metacarpals to those in the second and third digits. You'll appreciate they're short, and that's a very helpful clinical sign in diagnosing this parathyroid hormone resistance syndrome. What's the underlying problem? These people, they have mutations in one or more of the signaling proteins which are necessary to connect the parathyroid hormone receptor to intracellular effector pathways of parathyroid hormone action, and most typically those mutations are in one of the G alpha proteins, and one can, if necessary, look for mutations using molecular techniques in individuals in whom one suspects this condition. Here's yet another case of hypocalcemia. This is again a young man who was admitted to hospital with flu-like illness and non-specific symptoms for several days. He'd had some vomiting and nausea, abdominal pain, and over the past 24 hours or so prior to admission, developed severe muscle cramps. He'd had a few days of treatment with amoxicillin by his general practitioner. He didn't have any past history of note. He was not febrile, and but he did have clinical evidence of neuromuscular irritability, and that includes carpopedal spasm, which a particular position of the hand that is assumed when the hand is rendered ischemic by pumping the blood pressure cup up above systolic blood pressure, and you could Google carpopedal spasm or Trousseau's sign and probably find a picture of the characteristic position that the hand assumes in that situation, and that is a sign that is seen in patients with markedly low serum calcium. Chvostek's sign is elicited by tapping the facial nerve in the face, inducing contraction of the cheek, again a sign of neuromuscular irritability. And so he had evidence clinically of neuromuscular irritability. And indeed he was hypocalcemic, quite markedly hypocalcemic. He was hypophosphatemic. Other tests were normal, including importantly a serum magnesium, remembering that hypomagnesemia, which is pretty rare, but it is an important thing to consider in patients who present with symptomatic hypocalcemia. Other tests were relatively unremarkable, although they didn't have an elevation of the muscle enzyme creatine kinase, reflecting the marked muscle twitching and cramping that he'd had over the day or two before he'd come into hospital. He had an upper respiratory tract infection and symptomatic hypocalcemia with biochemistry, the low calcium and elevated phosphate, suggestive of hypoparathyroidism. He got some treatment with calcium and active vitamin D to stimulate oral absorption of calcium, and the symptomatic muscle cramps and twitches resolved. His phenotype was reviewed, and he didn't really have any other features of congenital forms of hypoparathyroidism. When the causes of hypoparathyroidism were considered, The most common is post-surgical, usually as a result of thyroid surgery. He hadn't had that. He hadn't had hypomagnesemia. He didn't have thalassemia or iron overload syndrome, and he didn't have any of the rare clinical conditions or clinical conditions which are rarely associated with hypoparathyroidism. He didn't have a congenital syndrome because this was a first presentation at age 25, and he didn't have other clinical features of those congenital syndromes. What he did have was a family history of when family members were tested of similar biochemistry. So he is the 25-year-old male in the bottom left-hand corner, the proband in this kindred. His mother had similar but mild phenotype with low serum calcium, low parathyroid hormone level, both he and his mother, and borderline elevated phosphate levels. So here looks like an autosomal dominant syndrome of hypocalcemia. So what this family has is an activating mutation of the calcium sensing receptor, such that the parathyroid glands read the ionized calcium, the extracellular fluid calcium level, as being higher than it actually is, and that tells the cells to switch off parathyroid hormone production. So parathyroid hormone production is low and calcium falls, but the cells are still sensing a higher level than is actually present. So it gives the combination of a low calcium and an inappropriately low parathyroid hormone level. So effectively hypoparathyroidism. It's difficult to distinguish from idiopathic hypoparathyroidism, but here the family history and, if necessary, genotyping of the calcium sensing receptor gives the diagnosis. So just to illustrate that schematically, remember that the calcium sensing receptor sits on the surface of the parathyroid chief cells and senses the extracellular fluid level of extracellular fluid calcium level. What is happening here is that the individual carries affected individuals carrying an activating mutation such that the receptor is continuously signaling to suppress PTH production irrespective of the level of extracellular calcium. So parathyroid hormone production is constitutively suppressed or switched off, calcium levels fall, and the patient can develop symptomatic hypocalcemic. A lot of these individuals don't actually develop symptoms. They have mild asymptomatic hypocalcemia. Remember also that calcium receptor regulates renal tubular calcium handling, and so in this situation again the receptor will be constitutively switched on, and the effect of that is to switch off the flux of calcium from the renal tubular to the extracellular fluid, so the reabsorption of calcium is inhibited, and so the patient has relative hypercalciuria. There's relatively high urinary calcium excretion in the face of low serum calcium. So this slide just summarizes the phenotype, if you like, of the two types of mutations in the calcium sensing receptor. The activating mutation represented by the green arrow, which causes the ADHH or autosomal dominant hypocalcemia phenotype, and the inactivating mutations, the red minus sign, which causes the benign familial hypercalcemia phenotype, where and they're basically mirror images of each other. So in the BFH situation, the serum calcium is so the receptor is functionally inactivated or less active. So the cells read a lower level of calcium that's actually present. PTH secretion is released and increased. Hypercalcemia, usually mild, ensues, and relative hypocalciuria or low urinary calcium excretion occurs. These are both autosomal dominant conditions, and they're pretty rare, but important to recognise, because the optimal management for each is actually to do nothing unless the patient with ADHH, they have symptomatic hypocalcemia, in which case gentle treatment with active vitamin D to maintain the serum calcium at the lowest possible level to avoid symptoms is indicated. So just to summarise the management for the patient we discussed at ADHH, no treatment if they're asymptomatic. If you do give them treatment when they're asymptomatic, you risk increasing that level of urinary calcium and causing a nephrocalcinosis and renal dysfunction. If they do have recurrent or symptoms of hypocalcemia, then minimal doses of vitamin D just to keep the level of serum calcium at an asymptomatic value is indicated. We've already discussed the ADHH features, so I'm going to skip over that slide. And we've discussed most of this, but just to recap, this is the flip side syndrome, familial hypercalcemia, which is a cause of PTH-dependent hypercalcemia. Important to ask about family history. If the patient has a family history of hypercalcemia, then this diagnosis should certainly be actively sought. The diagnosis is made by screening immediate relatives with serum calcium measurement, because it's an autosomal dominant condition. 50% of the person's children, and perhaps one of the parents ought to be a mutation carrier and to have the phenotype. Urinary calcium measurements can help because of the relative hypercalciuria in this syndrome, but genotyping is now commercially available of the calcium receptor. It's not now just currently a research tool. It is available in many laboratories, including locally. So finally, in this series of cases, I want to show the case of Mrs. B, who was an elderly English tourist who was seen in the emergency department at a local hospital 3 days after just a minor fall in which she twisted her right leg, and after which she had increasing right hip pain and difficulty mobilizing. She'd had a few kilogram weight loss in the last year. She was quite uncomfortable, and when x-rays of her pelvis were done, she was found to have a trochanteric fracture. Not sure if you can see the arrow in the presentation that you have in front of you, but if you look at the trochanter in the right hip, there's a lucent line right through the middle of it indicating a fracture, and if you look on the left, there's an incomplete fracture in the femoral neck in the superior aspect, and probably also the inferior aspect. Now, here are her blood tests, which are the abnormal tests are highlighted in red. She had a very low serum phosphate, 0.29 millimole per litre, with a markedly elevated level of alkaline phosphatase, and her other other liver function tests, so liver enzymes, were normal, suggesting that she too, like the vitamin D deficient patient we discussed earlier, has osteomalacia. Her vitamin D level was normal, and she had, is in the bottom, the TMP is a marker of phosphate, or a measure of tubular phosphate handling, and she had marked phosphate wasting as indicated by a low TMP. She clearly, because of her age, had an acquired hypophosphatemic syndrome, and as we discussed earlier, most of these syndromes feature or are caused by elevated levels of the phosphatone FGF23, and this was measured in Mrs. B, found to be markedly elevated, about 8 times the upper limit of the normal range. So what she has is a tumoral syndrome called oncogenic osteomalacia, in which a mesenchymal tumour, or a tumour of mesenchymal cell origin, elaborates increased levels of the phosphatone and FGF23, which induce renal phosphate wasting, hypophosphatemia, and over the longer term impaired bone mineralization, osteomalacia, and in her case pathologic osteomalacic fractures. It's sometimes difficult to find these tumours. They tend to be associated with skeletal structures, but they can be very small, and one technique is whole body MRI stir sequence, which was performed in her, and that indicated an abnormality which is arrowed in the slide here in the left ethmoid sinus, which was very suspicious for one of these benign tumours, one of these mesenchymal tumours. She had follow-up CT scan, which is shown on this, one of the coronal views is shown on this slide, and you can see the black air spaces are the sinuses, and on the right ethmoid sinus there's a nice air-filled sinus. On the left the sinus is occupied by a soft tissue mass that corresponds to the lesion seen on the MRI stir sequence, and represents an ethmoidal mesenchymal cell tumour that was elaborating FGF23, and she had that removed surgically, and that was followed very rapidly by restoration of normal phosphate levels. Her bones healed, and she needed no further treatment after that tumour was successfully identified.